Good afternoon, everybody. It's my great pleasure to meet you from Hradec Kralové, beautiful town in Czech Republic. We take part in Hradeckie Pulmonologické Dny, what means we take part in pulmonological days in Hradec Kralové. The meeting is organized by Physioassist and Inogen company, and we will be discussing new standards of treatment for lung diseases. It should be a wonderful discussion between pulmonologists who are mainly practitioners. And it's my great honor to introduce you wonderful people from all over Europe. On the left, you can find my excellent colleague from Poland, Dr. Joanna Milkowska-Dymanowska.
Good afternoon.
Then, just from Hradec Kralové, Dr. Michal Kopecki.
Nice to meet you.
Then, from the heart of Czech Republic, from Prague, Dr. Václav Koutsky.
Nice to meet you.
And with my great happiness, on the right, Professor Claudio Rabec from Switzerland now.
Good afternoon, everyone.
And Professor Ivan Solovic.
Good afternoon to all.
And last but not least, Dr. Pavel Pobecha.
Good afternoon.
Dear all, let me start with what I would dream to happen here while this time. We have more and more evidence about that, how valuable are airway clearance techniques. However, I think we are still in a vicious circle of problems with patients who have problems with infections and suffer from lung diseases. And we do understand that this vicious circle should be stopped, and we have a lot of tools which we try to use to be able to stop that. We must understand that the main cause we are here are our patients. And please let me introduce my wonderful patient who is suffering from one of the most severe asthma whom I ever treated. She is now 70 years old, and I've been caring for her for about 20 years. Nowadays, she has bronchiectasis in her lungs, what we can see on these CT scans. As you can see, they are not spectacular. However, understanding what happens with the history of this patient and what modern medicine is able to offer her is a real adventure and story about that, how our possibilities changes and what can we do more and more every year. Have a look. She's a patient who really has problems with obstruction. Her FEV1 is less than 1 liter. And when she started to suffer from bronchial asthma, she was only 10. And it was 1957. And this many years ago, medicine couldn't help her as much as is able to do it today. She was fighting with her disease, having great problems, mainly connected with infections. Many years took that doctors realized that she is suffering from common variable immunodeficiency syndrome. And it was the first milestone in her treatment because we were offered to give her intravenous immunoglobulins. And it was a great moment when she felt medicine can help her. But again, she started to have problems with asthma. Next great milestone for her was the possibility of using benralizumab, which stopped her symptoms for many months. But finally, because of her problems with bronchiectasis and infections, we, in the department where I work, in Poland, in Krakow, we offered her SIMEOX therapy, which was the next and final tool which really gave her a lot of beneficial effects. Have a look. Have a look at the circle again. Let's now start discuss what today experts from all over Europe can do for patients suffering from lung diseases using new standards of treatment. And now, please, let me introduce again Professor Claudio Rabec, who will give us firstly information about basic concepts of our topic, and then will show us very interesting case of patients whom he was caring for. Professor Claudio Rabec.
Thank you, Alex. Again, good afternoon, everyone. It's a good pleasure, it's a true pleasure for me to be here. And effectively, I will deal with a physiological update about clearance secretion. After that, I will present a clinical case. Let me begin with the beginning. I would like to thank some of my colleagues that helped me with ideas and photographs for my presentation. Dr. Jean-Michel Arnal, Professor Claudia Crimi, and physiotherapist Laurence Vigneault. The airway is not only a tube. The airway is that allow us to communicate, to our alveoli, to communicate with the environment. And this is a vital function because this tube allows us to breathe and allows us to have gas exchange. But as there is a communication between the lung and the environment, the lung is exposed to exogenous noxa, such as microorganisms, particles, and pollutants that could impose a risk to the alveoli. As you know now, the distal portion of the lung must remain sterile. So this tube, this airway, is able to protect the lung, at the same time giving the possibility to exchange gas to protect the lung against this aggression. And this sophisticated system is based in 3 pillars. The first is mucus production, the second is ciliary activity, and the third is an effective cow reflex. And these 3 functions may act synergistically to impede the lung to be exposed to such type of noxas. Let me begin with mucus production. And mucus production is a physiological function of airway. The mucus is produced by the submucosal gland, and this liquid has a particular characteristics with a protein that is mucin and the electrolytes that allow a fine balance to ensure a good hydration and humidification of the airway. This mucus shell is a layer that protects also the cells of the upper airway. And this is a first pillar to protect the airway against exogenous noxa. As you see in this slide, there is a variation in the characteristics and the quality of the mucus that could generate disease or complications. The first most important issue is mucin, that when it is increased, it increases the viscosity of the mucus and generate a difficulty to eliminate these secretions. The second abnormality is in the electrolyte balance in this layer that could also produce some complications. And the final pathway of this increased mucin and the alteration in quality of the mucus is a decreased clearance that can lead to infection, to inflammation, and the production of mucus plug that could impair respiratory function. So you can see here, when we moved with healthy state to different abnormalities, the mucus became more and more pathological, and with higher viscosity and elasticity, and it's more difficult to clear this secretion. It is important to say that this mucus is necessary to drown the particles and to expel the particles from the body. And as you can see here, the mucin could increase progressively, and the concentration of plasma proteins and inflammatory cells increase with the proliferation of bacteria that produce a vicious circle of inflammation. And this increase in viscosity and elasticity of the mucus explain a great part of the complication related to the muco-obstructive disorders. The second pillar is mucociliary transport. That is a system that is a sophisticated system to sweep secretion from the airway by little structures that call cilia. A good functioning of the cilia is crucial to eliminate the secretion, and this is active in the distal airway. The third mechanism that is important is the Cow's reflex, and the Cow's reflex is related to 4 different moments. The first one is irritation of the airway that trigger the Cow's, and after then there is an inspiratory phase in which the patient inflate the lung. The third moment is the compressive phase with the closure of the glottis, and finally an expiratory or expulsive phase in which the patient is able to eliminate the secretion of the upper airway. It's well known now that the Cow peak flow is a predictor of respiratory complication, mainly in patients with neuromuscular disorders, and a peak flow lower than 240 liters per minute is related to increase in risk of respiratory infection and respiratory morbidity. So the common cause of impaired clearance are related to these 3 pillars, or the abnormality of these 3 pillars. The first one is the mucus hypersecretion, the thickness of the secretions, a dysfunction of the cilia, a cow that is absent or not effective, and of course all that is clearly complicated when the patient has an artificial airway, such as an endotracheal tube or tracheostomy, because this system shunt clearly the mechanism of defense of the upper airway. So by taking into account this pathophysiology, we have 2 different mechanisms of airway clear impairment. The first one is in the proximal, that is related to a weak cow, and this is characteristic of neuromuscular and neurologic disorders. The second one is in the distal airway, and in this field, the most important issues are the mucus quality and the mucociliary transport. And this is characteristics in patients with distal affectation of the airway, that is chronic obstructive pulmonary disorders, cystic fibrosis, bronchiectasis, et al. What about the cow reflex impairment? This impairment could take place in the 4 movements of the cows. The first situation is, of course, the sufferentation of the upper airway with the lack of sensitivity, and this is clear in patients that inhale, that is not able to defend the lung against the exogenous noxa. The second is patient with the abnormalities in pulmonary function test by reducing the vital capacity, so those patients are not able to inflate the lung. In the third phase, the most important abnormality is glottis dysfunction, because the patient is not able to close the glottis and to generate the compression of the lung and the compression of the air to produce the next phase, that is expiratory phase. And in this expiratory expulsive phase, again, an abnormality in pulmonary function test, especially a reduction in vital capacity or in expiratory pressure, is related to to worsening in the cow reflex. What about viscosity of secretion? You can see here the almost the linear relationship between the mucin concentration and the probability to have chronic airway disorders. This mucin concentration is at the top, increase in primary ciliary dyskinesia, but also in cystic fibrosis because the quality of the mucin, the quality of the secretion are not good because the mucin concentration increase. But also in patients with COPD, this mechanism is very important, and he can perennize the irritation and the inflammation of the airway. Concerning the mucociliary transport, as you know, the paradigm of that is some disorders of the cilia transport, but also in patients with COPD, we can see these abnormalities in mucociliary transport that is more important as the patient in worsening pulmonary function in obstructive disorders. So what are the consequences of this impaired increase? The first one, of course, is respiratory infections. Because the mucus there is a stagnation of the mucus, and there is not clearance of the mucus, and so there is the high probability of infection. But also we can have the obstruction of the airway by this thickening mucus, by we call mucus impaction or even atelectasis. This is related also to dyspnea and increase in hospitalization, and in some cases, in patients that are not able to be managed without with the current treatments, we need to perform for this patient tracheostomy, especially when the cow reflex is impaired. How to assess this secretion burden? We can assess the secretion burden by analyzing the sputum quantity and quality of sputum, by clinical examination, mainly auscultation, but imaging. And now there is a lot of progress in terms of evaluation of the imaging in the distal lung by searching for mucus plugging and atelectasis. In the proximal airways, the most important tool is the use of peak cow flow. And as I explained before, less than 240 liters per minute is related to increase of risk of respiratory infection. In some cases, we need to perform bronchoscopy to clear secretion, but this is very anecdotal in clinical practice. But before the bronchoscopy, we have some techniques that are able to clearance the airway and to help the clearance of the secretion. And when the problem is in the proximal airway, there are some techniques that are able to improve the cow flow by using the IPPV, by using the percussion, or mainly the most important of this technique is to insufflate and to exsufflate the patient, to simulate and to produce a cow effort. In the distality, there are different techniques that we will deal with in the next slides. High flow nasal therapy, oscillations, and the technique of SIMEOX, that is intermittent intrapulmonary deflection technique. Let me explain quickly each one of these techniques. Cow flow augmentation is only to make as a patient, that is to inflate and deflate the lung to produce cows and to increase clearance secretion. And this is provided now by different ways. We can perform manual insufflation, we can perform NIV, but air stacking, that is the increase of tidal volumes until total lung capacity to inflate the lung. But the most interesting tool is the mechanical insufflation and exsufflation. Intrapulmonary percussive ventilation is able to increase vibration in the airway and to produce a movement that is more or less the frequency of the cilia to help the upper airway to clear secretion. An innovative technique now available is the intermittent intrapulmonary deflation technique. In this technique, we apply a negative pressure intermittently at 12 Hertz during only the expiratory phase. You can see at the right of the slide a graph of the flow, the high frequency flow, that allows to modify the rheological properties of the bronchial mucus and to improve clear secretions. Last but not least, we have high flow nasal therapy that have different mechanism of action, but the most important one in terms of clearance secretion is the humidification of a thick secretion that allow or to favor the clearance secretion. In the second part of my presentation, I will present you a clinical case of a 37-year-old male that is not risk, no smoker, no alcohol, but he present lower lobe bronchiectasis by unknown etiology. We don't know where this bronchitis appear, but the evidence that this patient in 3 years presented 6 episodes of infectious exacerbation. This is a history of the patient. As you can see, during the 6th exacerbation, he presented also an episode of hemoptysis without hypoxemia. The clinical case was complicated with the pulmonary basilar tuberculosis that we treated successfully with quadruple therapy. And at the end, he was colonized by Pseudomonas aeruginosa that was treated by inhaled colistin. In September 2024, this patient was hospitalized for infection exacerbation with hypoxemia. You can see at the left the CT scan that shows an impressive bronchiectasis with mucoid impaction, predominantly at the left, but bilateral one. And as you can see, that is not only the huge bronchi that are full of secretion, but also there are the little mucoid impacts in the peripheral airway that explain that this patient is very dyspneic and this patient is in respiratory failure. So we began antibiotic therapy and intensive respiratory physiotherapy. The patient present as complication bronchial bleeding that need embolization, and he was transferred to intermediate care unit because his inability to clear secretion and the worsening of this dyspnea and hypoxemia. We tried a lot of techniques to clear secretion, chest physiotherapy, vibrating PIP device, NIV, and intrapulmonary percussive ventilation. And despite that, these patients remain very ill with secretion clearance that remain ineffective. And we try in this patient an intrapercussive expiratory technique. And this is the step on implementation. This technique is only an expiratory technique, and it's very easy to understand, to be understood by the patient, very easy to use. We can vary the power of the device and check the efficiency, and we can evaluate the number of cycles performed in the memory of the device. So the idea is to provide to the patient a session of 3 for 10 respiratory cycles with 45 seconds of rest during 15 to 20 minutes. The patient became autonomous in 2 days because the technique is so easy to be performed by the patient. And it doesn't need a lot of learning method. So we introduced 2 sessions a day. The patient was autonomy on the second day and controlled by respiratory physiotherapist. The patient tolerated well this technique. There is not fatigue. There was an improvement of MMRC score from 4 to 3. And the patient was able to return home with this device at home and the expectoration, that is the clearance secretion, was come back to the usual level. And 6 weeks after, we performed a new CT scan, and the results were surprising and impressive. And as you can see here, that the bronchi that were filled by secretion were most of them clear, not only in the most important, in the cylindric bronchiectasis, but also in the peripheral mucus impact. As you can see, mainly at the right, there is a reduction of the lines in the lung, and these lines, there are bronchi that are full of secretion. So the question is mucus plug, and what are mucus plug? Mucus plugs is the consequence and the complication of an increased mucus production and viscosity combined with impaired mucus clearance that led to obstruction of the airway. You can see at the right an image of the mucus plug in distal airway. This is an image that was I thanks to Claudia Crimi for this image, and it's very impressive to see that. And we are able now with modern techniques to evaluate the lung in each section of the lung to assess the importance of this mucus infection. And in fact, this mucus impaction are the consequence of low airflow rate that are insufficient to transport hyperconcentrated mucus. And the use of techniques that increase this airflow rate and modify rheological condition of the secretion are able to improve a clearance secretion. When a mucus plug is present, there is a reduction in expiratory airflow, the increase in air resistance, the air trapping, increase of wall of breathing because hyperinflation, worsening of ventilation perfusation inequalities, and this led to hypoxemia. This, to clear this mucus plug, improve not only hypoxemia and help to reduce to control infection, but also there are some papers that show that they are able to improve significantly the pulmonary function test with increase in FE1 of 200 or 300 milliliter that is never attained by bronchodilation. And these mucus plug are related to airway obstruction, and not only in patients with cystic fibrosis, bronchiectasis, or chronic bronchitis, but also in patients with emphysema, because there are some papers that show that 1/3 of patients with emphysema have silent mucus plug, and this could impact in a pulmonary function test. But this is also related with exacerbations. That is, the more the mucus plug in the lung, the more the probability to have clinical exacerbations. And last but not least, in this very interesting paper published by Diaz in JAMA 2 years ago, there is a clearly relationship between the quantity of mucus plugging, but using the mucus plug score category, that is the analysis of the lung in sections and to evaluate the number of sections that are affected, and when the number of sections that are affected by the mucus plug is increased, there is increased mortality in this COPD population. So, as a conclusion, I can say that secretion clearance is vital in acute and chronic care. And the airway clearance is impaired in patients with respiratory disorders, not only in classical patients with respiratory disorders such as bronchiectasis and cystic fibrosis, but also in patients with COPD and other etiologies, and we will deal with that in the presentation of my colleagues in the next time. It's very important to understand the mechanism of this improvement, this worsening of the clearance to determine the optimal treatment. If the problem is in the proximal airway, we need to improve co-efficiency. But since the problem is in distal airway, we need to improve mucus quality, mucociliary transport, or to change rheological characteristic of mucus and remove mucus plugging. And this technique of SIMEOX is a very interesting tool because it's a physiologically based mechanism of action, improves clearance secretion both in distal and proximal, and is the only tool that is able to act at both mechanisms. Is more effective and faster than other techniques and less fatiguing, and is easy to use because the patient has only to take the mouthpiece and to breathe inside, and this is all. And this technique has a main interest for clearance secretion in fatigued patients with dyspnea that limits the ability to clear secretion by using the conventional techniques. Thank you very much.
Claudio, thank you very much. It was great. As always, I learned a lot. I'm sure that you showed that physiology and pathophysiology is very complex, sometimes complicated, but it was spectacular for me to understand that there is a relationship between plaques and mortality, because it suggests that our fight with plaques and our activity which we want to do now is valuable because it is something what may be a tool to decrease this mortality. Of course, we have not nowadays enough evidence to say that, but it suggests we should do our best to go this way. Thank you. When we were preparing this meeting, I was discussing speakers with Madame Marguerite Michel, and we were wondering if we should touch aspect of children. And when I realized that my patient whom I started with our meeting today was only 10 years old when she started to suffer for her disease, I understood, yes, we must have someone who cares for children. And it is this moment when I want to ask Dr. Václav Koučky to start his presentation and say us about his experience with SIMEOX and children.
So good afternoon, and thank you for the invitation to this interesting meeting. Please could you send me the pointer to change the slides? Yeah. So thank you for this invitation and the possibility to share my experience with the SIMEOX treatment in pediatric patients. I'm from Motol University Hospital, from the Department of Pediatrics, and we closely cooperate with our colleagues from the Department of Rehabilitation and Sports Medicine, and I would like to show you some of our indication for SIMEOX. To start with, I would like to show you our clinical approach to SIMEOX treatment. So we consider SIMEOX as a step-up therapy in patients with severe forms of chronic suppurative lung disease, mainly in cystic fibrosis, primary ciliary dyskinesia, and also other forms of chronic suppurative lung disease, such as airway instability, primary immunodeficiencies, etc. Of course, we have also cases of chronic suppurative lung disease of unknown etiology. Not all of our patients are already in the stage of the bronchiectasis, but most of them suffer also from the bronchiectasis, so there's an overlap between these two diagnoses. We consider SIMEOX as an additional treatment to standard chest physiotherapy, which standardly contain hypertonic saline inhalation, in some cases also some additional drugs to inhale, for example, DNAs or antibiotics. And of course, all the patients need to perform regularly their airway clearance techniques. For example, they use different devices of the positive expiratory pressure systems or oscillation PEP systems or autogenic drainage or combination of these techniques as judged by our expert physiotherapists. When we are speaking about the pediatric patient, what is very important is the cooperation and gaining some cooperation from the patient, because the technique, how you perform the chest physiotherapy is very crucial, and it greatly depends on the age of the patient and of course also on the experience of the child with the medical environment and the ability of the personnel to get a good relationship with the with the patient. So as a rule, we perform SIMEOX mainly in children from the school age on. However, in selected cases, we may also try it in the preschoolers, but it's on the individual basis. It depends on the child itself and, of course, on the experience of the personnel. How do we prescribe SIMEOX in Czech Republic? So unfortunately, we don't have regular reimbursement for SIMEOX in Czech Republic, but we may make a special request for the approval of this therapy. It's on individual basis in selected most complicated cases, and in most of them we are able to negotiate with the insurance company to have the reimbursement. However, there are no standardized criteria for the prescription, so it's based on the individual basis. Fortunately, we are also able to offer this therapy to our patients during the acute exacerbation, because we have 2 devices in our department which are available for our patients who are either hospitalized, for example, for the IV antibiotic treatment, for example, in CF or PCD when there is an exacerbation, or we may provide this device to home for this patient for 1-2 months when they are properly trained during the hospitalization, and then they may continue at home. Moreover, there are different patient clubs or patients associations which also support these patients with chronic lung diseases, and they are also able to provide these devices for some time. So basically there are two options how to prescribe SIMEOX, so on-demand therapy or long-term home therapy, I have outlined in this slide. With my colleagues in our department, we also wondered if we are able to add some evidence to the indication of SIMEOX in patients with primary ciliary dyskinesia, and that's why we designed this study, which was focused on the short-term effect of chest physiotherapy with SIMEOX on lung ventilation inhomogeneity and other aspects of lung function. We know very well that there is quite little evidence for the physiotherapy in general in pediatric patients, and of course also the evidence for SIMEOX use is also not so big, so that's why we initiated this study. It was a randomized interventional crossover study. There were three meetings in this study. The introduction, K0, when the patient get familiar with the therapy, with the SIMEOX, and everything was explained to them. Then they were randomized to the 2 arms of the study. The first one was the pari-OPEP first arm, and the second was SIMEOX first arm. After 3 months, these 2 groups were crossovered, so they had the other type of therapy, and we compared the effect of the 2 different therapies. As you can see, there was no possibility to blind the study, and we designed this study as a non-inferiority study. We wanted to show that the shorter therapy with SIMEOX is not less effective than the standard therapy with pari-OPEP. Here you can see our study population, so it was focused on patients with primary ciliary dyskinesia. We enrolled only patients with confirmed diagnosis, that means conclusive electron microscopy findings or genetics. The age span was from 4 years to 18 years because we were focused on the pediatric patient and we wanted to have a good cooperation. That's why we didn't go to the younger category. And all of the patients were on a standard chest physiotherapy with pari-OPEP, and they performed it on daily basis. The exclusion criteria included poor compliance to the standard chest physiotherapy and the inability to cooperate during our study or during the interventions. We also calculated the sample size based on our data on the variability of the LCI in PCD patients, and that was our results. 30 patients needed to be included. Here's some more details on our intervention. So the first type of intervention was pari-OPEP therapy. It's a standard chest physiotherapy. The pari-OPEP was used in 4 different positions, and at the end of the expansion there was the huffing, and the duration of this therapy was 30 minutes. The second type of the intervention was the treatment with SIMEOX. It was scheduled for 20 minutes, and the technique was as per manufacturer's recommendation. What were our primary outcomes and secondary outcomes? So we focus on the short-term change in lung ventilation inhomogeneity. So you can see that we were just assessing the short-term effect of this therapy. We were not able to perform a long-term assessment. So we used the lung clearance index as a primary outcome. It was derived from nitrogen multiple breath washout, and it was targeted to the small airways, the most peripheral airways, because we know that in PCD patients, the disease starts mainly in the periphery of the airways. So that's why we didn't want to use spirometry as the primary outcome, because there may be less sensitivity of the FEV1 and FVC and the standard parameters taken from the spirometry. The secondary outcomes, of course, we used the spirometry, force and slow, spirometry vital capacity, FEV1, and also maximal expiratory flows at the periphery of the or the lower levels of the FVC. We also assess the functional residual capacity because it's one of the two main outcomes from the nitrogen multiple breath washout. And also we assess the distribution of the ventilation between the left and right lung. We use a novel method, electric impedance tomography, which shows you the distribution of the air in the lungs in real time. Of course, our physiotherapists also added some outcomes, and they assessed the respiratory amplitudes in different levels of the thorax, and also they measured the change in thorax configuration. The study already ended, but we were not able to publish the results yet, so we are one of the first to see our preliminary results. So in the table you can see patients' characteristics. The mean age was 12.5 years. There were normal anthropometry of this patient, height and weight, as expressed as Z-score. You can see that these patients were quite ill with respect to the peripheral airway disease. You can see LCI Z-score severely increased, more than 6 Z-score. However, the volumes of the lungs were quite fine, FVC and functional residual capacity, both in normal range, and there was tendency to the airway obstruction as judged by Tifeno index. You can see that the mean value was within norm, but there were several cases with airway obstruction as judged by this parameter. I would like to add that in pediatrics, this Tifeno index is not so sensitive to the peripheral airways, as you can see on the comparison between Tifeno and LCI. You can see patient had very severe increased LCI, but nearly normal Tifeno. So what did we find in our patients? So we found a statistically significant decrease in LCI, that means ventilation inhomogeneity, both in SIMEOX and peri-OPEP treatment during single intervention. However, the magnitude of this change did not reach the clinical significance as judged by the coefficient of repeatability. In some patients it reached, but as a whole group it didn't reach the clinical significance, but the statistical significance was there. And what we also find that the change in LCI did not differ between SIMEOX and peri-OPEP intervention, so that show us that there is similar effectivity, or that the SIMEOX is not inferior to peri-OPEP. And you can see that the peri-OPEP has 30 minutes of therapy, SIMEOX 20 minutes, so there is some possibility to shorten the duration of the everyday chest physiotherapy. We also checked how the LCI changed during the whole study. It was scheduled approximately for the 10th month, if you remember the initial scheme. So it was 3 months between the 3 visits. So in total it took 10 months because there were some delays, because it was also during the COVID era, so there were some technical problems. But during the 10th month, which was the study performed, so we found mild improvement in LCI, which may be interpreted in that way that performing this highly effective therapy may also increase the LCI from the long term of point of view. So to conclude, so we may say that SIMEOX may decrease the burden of daily chest physiotherapy in PCD patients. And to finish my presentation, I would like to show you one of our favorite patients, a case report of Simona. So she was born in September 2005. So now she is already in the care of adult pulmonologists, but I remember her very well from the pediatric era. So she was dispensarized in our department since the age of 3, when she was referred to us with the increased respiratory morbidity, repeated upper and lower airway infections. At the age of 5, we made the final diagnosis. It was PCD. It was, so we found the mutation DNHA5, and it corresponds to the autodename arm deficiency in the transmission electron microscopy. She suffered from the chronic sinusitis, chronic suppurative lung disease with lower lobe atelectasis, tracheomalacia, and later bronchiectasis developed. You can see that the airway microbiology was also very complicated besides the standard pathogens, strep pneumonia and Haemophilus influenzae. She also was colonized and suffered some exacerbation caused by Stenotrophomonas maltophilia and Exophila dermatitis. So she was on quite intensive treatment, as you can see in here. But despite that, there was a progression of her disease, mainly during the year 2018, when we were very sad about her deterioration. You can see some chest CT scans and also findings from the bronchoscopy, very severe mucopurulal and bronchitis. So here you can see also the lung function, which was not so favorable. So that's why we decided to escalate her therapy. So she underwent several courses of antibiotic therapy. She had some immunoglobulin substitution, repeated bronchoscopy to clear the airways. There was a respiratory insufficiency, so she started with home oxygen, and later we put her on home non-invasive ventilation during night. And also we extended the physiotherapy, and it also included the SIMEOX. Here you can see some more details of the treatment, as it was designed by our physiotherapist. And here you can see the results of our intensified efforts. Here is the chest CT from the November 2018, before the initiation of this therapy, and in February 2019, how it improved. Here are some more pictures. You can see that in general the bronchiectasis could not be removed, but as shown previously, the mucus plugs could be partly cleared. Here you can see the lung function, that we were able to stop the deterioration of the lung function, and even to gain some more percentage of her FEV and FEV1 and FVC. So to conclude, SIMEOX may be an effective add-on therapy in children with different forms of chronic suppurative lung disease and bronchiectasis. There are different application schemes based on the individual needs of our patient, and based on our preliminary results from our study in PCD patients, SIMEOX may shorten the time of physiotherapy and may help prevent chronic respiratory muscle fatigue. So thank you for your attention.
Dr. Václav Kołucki, thank you very much. Thank you for that you showed us how to build evidence we needed to understand more, and thank you for this excellent case proving effectiveness of your work. My dear audio audience, please remember that you can ask the questions, and please do that. We promise to answer all, even if we are not able to do it after our presentations. I promise, and we promise, that everybody who will ask the question will get the answer via mail if it will be necessary. And now I want to take you with our journey with SIMEOX to completely different topic, which seems to be very interesting for me, because Dr. Michał Kopecki, who will be next speaker, will tell us now about his experience with SIMEOX as a tool which helps early recovery among surgery patients. You are welcome.
Yeah. Thank you for invitation. I am from the small department in our university hospital, so we have only 21 beds where our patients lie. And also we have our IC unit where we have 8 beds, and that's why where we use really the physiotherapy. And why we use the physiotherapy? Because we have the acute problems in our patients in our IC unit, and also in our pulmonary department, and also we work with our patients who we takes care of several diseases in our ambulatory tract. And we have very good cooperation with our physiotherapists. And we use your cooperation to prevent many risky factors who can worsen our patients. So here are the mentioned because it was mentioned before. And we mainly have the men, and these persons are middle-aged, and this is mostly treated in our department, and this is a story of the man who is 72 years old man. He suffered from diabetes, hypertension. He was after the nephrectomy due to cell carcinoma. From his habits, he was a smoker, 25 pack years, and from your risky jobs, he was a locksmith, so there was a contact with some methyl. He came to us with the coughing, repeating respiratory infections. There were fever. He feels very fatigued. There was a lost weight of loss about 10 kilos. There was night sweating. Sometimes during the infectious, they suffer from hemoptysis, and there was persisting coughing. We examined this man, and on the X-ray we can see that there on the right side in upper lobe we can see some atelectasis at first in the X-ray. Then we used the CT. There was a cavity, and we didn't know nothing about the etiology of this cavity. So we take some samples. Also the bronchoscopy. There was a lot of mucus. We take the bronchial lavage. We sent to the examination, but we don't really know what was the reason there. There was some metaplastic problems inside in the cytology. There was also some types of bacteria and so on, but nothing special. And he was repeatedly treated by the antibiotics, but there was the same status of the patient. And due to our multidisciplinary team, we decided that the best way how we can solve this problem will be the surgery. So before the surgery, our patients have functional testing, and when they don't have the normal functional testing in the spirometry, body plethysmography, and also the functional testing. So we put the spiroergometry to the patients to decide if we decided there will be some surgery. We put the segmentectomy or lobectomy, and we know that in this case the peak of volume of oxygen was high to take some surgery. Also, when we have the patients before the surgery and before the training, so we use the examination of strength of muscles. And now we can see that a lot of our persons have the very weak inspiratory, also the expiratory muscles, and there was very fatigue during this procedure. So we we have to take care about the increasing of the strength of muscles, and we use a lot of techniques. So if our surgery said that there is the indication of the surgery, so we are able to take only segmentectomy or lobectomy or pneumonectomy. And if we have the time to the surgery, so we use the ERAS protocol. But if the situation is very risky from the carcel, or we don't know about the etiology, so we don't have so much time to put the ERAS protocol and to train the patient before the surgery. So we have only short time to increase or educate the patient for some expectoration, because we know that the increasing of mucus after the surgery and also during the hospitalization, the patients very worsens when they are not very prepared before the surgery. So we can mention the control breathing or thoracic expansion exercising or forced expiratory techniques or huffing or something else. We use the drainage technique with the aids or without aids. We use the acapellas, power breaths, and so on. And if we have the time, so we train with the thresholds, power breaths, and to increase the strength of muscles, because we know it was mentioned that when the peak flow is low, so the persons are very risky to increasing the mucus inside the lungs. We decided in some cases when the patients are very cooperate to use the SIMEOX. We know that there are some contraindications, but there are the relative contraindications, and we have only a small amount of patients when we use the SIMEOX. And at first, before the surgery, how long we have the time, so we educate the person, and we trained the autogenic drainage, and we use also the physiotherapists to force the physiotherapy. This person undergo the lobectomy. This is the spirometry after the surgery, and there is also the reduction, but we put the one lobe outside, so it's normally there is no obstruction. And we continue with the using the SIMEOX after the surgery, and he trained very well. This is the scar on the left. This is the X-ray after the surgery, so we can see that the upper lobe is outside, and there was location other lobes in the atypic positions, and also on the CT we cannot see no cavity. There is small amount of mucus, and that's why we use also the SIMEOX, not only the SIMEOX, but in this case SIMEOX, and we trained persons, and they can use it also in the hospital, sometimes at home. And it's very helpful, and it's comfortable for our patients. I'm not sure, yeah. This is the video. At first, the patients wants to breathe only with the help with the physiotherapist. We can use the fixed position. Also, we used, in this case, he's sitting on the gym ball, and also we can force more strength, and we can more focused on the expiratory muscles in this case. So, in our center, we cooperate with our surgery. We have the pneumothoracic center, our surgery center last year We have more than 400 lung surgery operations, and about half of them were the lung resections, not only for some inflammatory processes, but also for the lung cancers. In this case, we use the SIMEOX. We have only small experience with using the SIMEOX, but for patient, it's more comfortable opposite the cough assist and so on. And we know that the patients cooperate more than in other equipment, because it's more efficiency and funny for them. In this case, and in our country, we can use also the SPA treatment. So in this case, the person continue after the hospitalization. He was indicated to the SPA treatment, so it was also possible to follow this physiotherapy. And why we take this physiotherapy? Because it improves the breathing efficiency, reduce the problems of the persons or patients, and it increasing the quality of life of our patients. So for us, it's useful. It's, I think, comfortable for the patients, and it's easy to use. Thank you very much.
Thank you very much, Dr. Kopecki. I think it's time to open much more us and to open audience to ask the questions. I think that we really touched a few important things with SIMEOX therapy. We showed effectiveness of method. However, as always, very important aspect is safety and how easy method is to be used. And I am not sure if I am right, but I thought that presentation of Dr. Wacław Kołcki and showing that methods used among children is safe and easy is very important information, because generally I think we should agree that if something is safe and easy among children, it rather means it should be safe and children among adults. So we can be much more brave. But your presentation, Dr. Michal, touched much more aspects of safety and indications and contraindications, because I think that a lot of us would be afraid to use such technique among patients who were just operated on. You showed us even a list of contraindications. Joanna, how do you think that this list of contraindications which was shown should be and can be the same for just SIMEOX therapy?
Well, I believe that in SIMEOX therapy, according to the manual instruction, there are no absolute contradictions. However, we need to look at those situations. That's why I'm really asking about this risk of bleeding and pneumothorax that might be one of the contradictions. That we will, in our clinical practice, will just think more probably, and we will more try to be safe. Yeah.
I think we use this therapy when the patients are in stable status. Yeah, it's not immediately after the surgery. That's the first time. And
how many days after surgery do you start to use it?
We use them. Sometimes when they have some robotic operations and so on, they are able to go with 5 or 7 days to home. Yeah, so we start very early. It was this case. So they came because they are not followed by surgery and they are sent to our department. So we indicate the following of the physiotherapy. And when there is no risk and we use we used the X-rays and so on. There was no clinical findings. So we try to follow using the SIMEOX, because when there is no more changing with pressures, because it's on one level of pressure, so there is no, I think, there is no more risk to damage the tissue. I know that there is very early after the surgery, but we don't have any complications, but we indicate it only in the stable patients when we have that there is no risk, I think, to bleeding, because sometimes when there are the cancers and so on, so it's very complicated, I think.
Thank you very much. Next aspect is how easy is something, and it is a moment I want to say I miss something, and we discuss here physiotherapy, and I miss here physiotherapists. Because physiotherapists are people whom we cooperate with very much, and without whom we wouldn't be able to do this, what we comment here. And I don't know if you agree with me, Claudio, but I think that it can be easy using SIMEOX because we have good, well-educated physiotherapists. Can you tell us how do you cooperate with your physiotherapists here?
Yes, thank you very much for your question, Alex. Yes, I think that this is a crucial issue. Physiotherapists are clearly a key personnel in our clinical practice in respiratory disorders, mainly in this type of patients. I think that their activity and their competence and their expertise is very important to deal with this type of situations. At the opposite, I think that while there is not very easy for a patient to learn some other techniques, some, for example, insufflation, exsufflation, or autogenous drainage, here this technique, in my experience, is very easy to use. And there is not a learning curve that in other techniques. In our patients, they learn very, very quickly to do that. It's only to breathe. It's only for us to find clearly the good setting, and to the patient to breathe inside the mouthpiece. We try that even in patients with tracheostomy. That is outside the clinical recommendation, but it works very well. And in this patient, it's more difficult because we need an interface for that. But I think that differently from other techniques, the presence of physiotherapists is always, of course, very important. But the patient is able to deal in autonomy at home, even without the help of the family. That is something that is very important in other techniques in physiotherapy. So this is my experience.
Thank you very much. It was a voice from Switzerland. We had a voice from Czech Republic, from Poland, and it's now time for a voice from Slovakia. And let's start to discuss something what is very common, and everyone who is a pulmonologist every day care for this group of patients. We will now mainly discuss COPD and asthma patients, and please, Dr. Pavel Pobecha, show us your experience.
Thank you very much, Dr. Kania, dear professors, dear colleagues, dear audience. I'm very happy and pleased to be able to share our experience with this unique innovative treatment in our center in Košice in eastern Slovakia. May I have the pointer, please? Thank you very much. So airway clearance techniques belong to standard management in our department, and physiotherapists as well are the part of our personnel, and they are very important. And we have experience with two type of devices. First are cough assisting devices or mechanical insufflation, exsufflation devices, mostly in neuromuscular diseases, And currently we prefer them mostly in uncooperative patients, and also very happy about using them in tracheostomized patients. But we have also SIMEOX, and availability of this therapy increased our interest to use it also in different types of patients with different diagnoses, with airway diseases, with patients which are cooperating but have problem with airway clearance, have problem with mucus plugs. We have also possibility in Slovakia to prescribe devices for home care, and based on the expert opinion paper of our respiratory society since 2020, we have possibility to prescribe cough assist devices for mostly neuromuscular diagnosis. We want to revise this document in this year or next year together with Czech experts. Other diagnoses like airway diseases are rarely indicated for this diagnosis. But we have SIMEOX, and based on the opinion of the Slovak Respiratory Society, represented by Professor Solovic, we have included SIMEOX in the list of categorized medical devices since 2021 for 4 diagnoses. Unfortunately, the same year, a little bit later, the COPD has been removed from the indication diagnosis, and the remaining 3 diagnoses, not sure what is happening, remaining 3 diagnoses can be prescribed for home with this device, and there is covered by health insurance company 1 pack of circuits of the hoses per year, which for some persons or patients can be not enough. We have experience since 2021 with this device, thanks to European Union project Partnership Without Borders. First device was since 2021, and we have also second device since last year. We started treating our patients with cystic fibrosis in our center in Košice, and currently we have experience with 10 patients with cystic fibrosis which have home care treatment with SIMEOX, and furthermore, with not only this diagnosis, but also 3 patients with not CF bronchiectasis, with already prescribed with SIMEOX at home, and 1 patient which was discharged recently from our department is currently following the outpatient rehabilitation physiotherapy. This outpatient rehabilitation physiotherapy started last year in the rehabilitation department in cooperation with our department, and it comprises complex pulmonary rehabilitation, 10 visits, including SIMEOX therapy, and we indicate patients with CF, also non-CF bronchiectasis, and we plan to include also patients with COPD this year. I have 3 very short case reports. The first, all of them are non-CF patients. The first is 50-year-old male patient with uncontrolled, persistent, difficult to treat bronchial asthma, which has CT scan verified bronchiectasis bilateral, and already he is ex-smoker and already on triple inhaled therapy. Here are some CT scans, and following up this patient showed that CT scan on 2023 revealed new consolidations in his lung based on the mucus plugs. And we included SIMEOX in his therapy. Here we can see stabilization of his X-ray during this treatment. Before this treatment, he suffered from repeated outpatient-treated exacerbations more than 5 times per year, included 2 hospitalizations. After this treatment, there was only 1 hospitalization and significant reduction of ambulatory antibiotic use. This patient is colonized, as many of our patients, with Pseudomonas aeruginosa bacteria, but there is also reduction of hospitalization and patient symptoms improvement. Second patient is 26-year-old patient, also with bronchial asthma, also suffered lately with or before with Mycobacteriosis, Mycobacterium avium. She's allergic to antihistamine, to dust, pollen, tomatoes, and milk intolerance, non-smoker, and CT scan verified dystalletatic changes in her lung. I will show it here. On the left side, you can see that there are some dystactic change, also bronchiectasis, and this finding on posterior anterior X-ray, we will see it later, is hidden behind the heart shadow. This is the problem because normally we perform only the X-ray. Here in CT scan in 2024, the CT scan revealed the progression of this atelectasis, cylindrical and varicose bronchiectasis, and also in the right middle lobe, new finding of the atelectasis. And we can see that after SIMEOX was induced in the therapy, there was a substantial regression of these findings. This is the finding, as I mentioned on the X-ray, that hidden behind the heart shadow, we were not able to see before the incipient condensation, but there was a progression of these shadows in 2022, and currently we can see that there is a regression of these shadows. This patient suffered also from repeated outpatient treated exacerbations and hospitalizations, subjective chronic feeling of phlegm and a lot of coughing, expectoration. After implementation of SIMEOX in this treatment, there was only one outpatient treated exacerbation only with pure antibiotics and a significant relief of symptoms. The last case is a 56-year-old patient, interestingly, with histologically confirmed non-UIP interstitial lung fibrosis, recurrent pneumonias, bronchiectasis, which were verified, also some allergies, colonized by Pseudomonas aeruginosa. And this patient, during the follow-up on X-rays, there was finding of progression of the shadows, which were not compatible only with pure fibrosis. And CT scan revealed new consolidations, bronchiectasis, and also some GGOs. We prescribed this patient with SIMEOX, and after, this was not the fibrosis, because after this treatment we can see that there is a significant regression of these shadows, which were possibly because of these mucus plugs. Patients suffered from repeated outpatient exacerbations and hospitalization. After SIMEOX treatment, there is 0 exacerbations. So I can summarize that SIMEOX has proven its effectiveness in clinical trials, and we have our own good clinical experience. There is increasing awareness of this treatment. In Slovakia, we have position papers and publications, and patients which are aware of this treatment prefer and also demand this treatment, and they are not only cystic fibrosis patients. This device has been included in the list of categorized medical devices in Slovakia for now for free diagnosis, unfortunately not the COPD. And there is increased use in our hospital, in our department, and in comparison to cough assist devices, this is the preferred device by our physiotherapist. We are also seeking for new indications like acute use in post-surgery and also some post-traumatic indications of airway clearance techniques and some more. Because we prepare the Slovak guidelines or expert opinion paper for using this device, this is under construction now and want to release it in our Czech and Slovak International Respiratory Congress in High Tatras this year. So we want to implement also the parts of our discussion to this document, and we are very happy about this round table. And this is how artificial intelligence sees SIMEOX in the future. I really want to thank you for your attention.
Thank you very much, Dr. Pobeha. It was very nice to hear your experience. Now I want to invite you to a wonderful place. Who loves mountains should go to Vyšné Hagi to look like it looks like when you have wonderful hospital with wonderful place. Professor Ivan Solovic, feel invited to introduce us your experience with SIMEOX.
Thank you very much for the invitation. And yes, I will speak about the SIMEOX therapy in our patients with COPD and asthma. Exactly, we were the first working place in Slovakia, exactly first clinic in Slovakia, which started 8 years ago with SIMEOX. SIMEOX that time mostly cystic fibrosis patient, but we were also the first one which started with COPD patient. Exactly, this is what we know, that SIMEOX allows the patients to perform long and passive expiration by successive low pressure signals, and we know that between each low pressure signals the patient is reconnected to the atmospheric pressure, which combined with passive expiration avoids physiological airway collapse, the main obstacle to the congestion of the peripheral airways. Also, this was mentioned by the pathophysiologist, so that throughout the session the patient spits up the secretion himself, and SIMEOX therefore is interesting alternative in order to make the mucus more easy to mobilize. Now this is the picture which was shown by my speaker, and these are our practical picture from our patient. Exactly, this is the former pathologist, medical doctor, who was cooperative and one of the first our patients which was working with us. Exactly, he was a very technical oriented person, and like typical pathologist, never-ending questions, why, and how, if it's safe for me, and if no. And exactly when we are speaking about the safety and indications and contraindication, exactly I think the only one where I will not give SIMEOX therapy are the patients after lung transplantation, because in this patient it was not, we do not have practical issues, so that otherwise exactly I think is no. So the study which we started in Slovakia, exactly it is in 2018, so this is 7 years ago. There were feasibility of airway clearance by SIMEOX as compared with manual physiotherapy in the treatment of hospitalized patients suffering from COPD and asthma. Exactly, this was also a great thank to our physiotherapeutical department, and that yes, we have in-house our respiratory physiotherapeutist, which we have at the moment 11 of the physiotherapeutists who are working full-time only on the lung disease, on the lung and after thoracic surgery patients, so that these are the possibilities. So objective of the study was to demonstrate the non-inferiority of this device versus traditional. By changing the physical properties of mucus, SIMEOX helps mobilize secretion and transport for disposal. The SIMEOX technology so allows to decrease secretion viscosity, improved mucus transport for disposal, a succession of passive expiration for distal tract disorders, ergonomics suitable for an autonomous use initially or in addition to the physiotherapist intervention. At the beginning, it is necessary that in case you have very good trained physiotherapists who are working and are by the first, second sitting with the patient, then it gives better results as so that at start also when we have new colleagues who are coming to the physiotherapeutical department, at start they trained on themselves and then with the patient, because it's necessary that all the persons who are doing the training with the patient, but also when the young doctors are coming, they need to go through the physiotherapy if they understand the principle and how to explain to the patient, because yes, for the patient, it is so that endpoints exactly also that feasibility or ability to properly use the device as evaluated by patient's preference. Do 2/3 of the patients prefer the SIMEOX therapy over the standard physiotherapy technique. And secondary, it was the ability of the patient to properly use the device, safety, no adverse events, patient-reported outcomes, any pain reported, changes in the saturation of the oxygen, and duration of clearance therapy session. Inclusion criteria, exactly as it's age more than 18 years, because we are working with the patient, only with adult patient, COPD, asthma, bronchial or confirmed or ACOS. That time patient reported symptoms of excessive mucus and problems to clear the mucus, and reference therapy, traditional manual physiotherapy technique performed by the physiotherapist. So that there were 6 SIMEOX sessions in-house, before and after the session, examination of blood gases and acid-base balance, repetition, program 1, 4 × 6, so 24 expiratory cycles, program 2, 4 × 8 cycles, and program 3, 4 × 10 expiratory cycles. Power was between 25 to 50%, and monitoring of the expectoration during the session and after the session. Together in the group, our group of patients were 15 patients, 10 men, 5 women. Ability of the patients to properly use the device during the first session, it's so that the approximately 15 minutes get acquainted with the SIMEOX. This is very important that when the first session is exactly, you need to think it takes a longer period, needs more time as the second and the following session, so that time also, in case you are planning the sessions with the patient, the first session need to be minimum 10 to 15 minutes more as other sessions, because by the first session need to be the properly use of the device during the patient need to be familiar with the device, because yes, it is easy, but on the other hand, yes, still it is something new in the mouth. Patients reported outcomes, no pain reported in our group, changes in the saturations were plus 0.4 to 1.4 kilopascal improvement, and duration of the clearance therapy session were between 15 to 25 minutes. These were the analyses of the group of patients that time, so that you can see that exactly sessions, all the patients, number of sessions were 6, and how they were accepted by the patients. And this is the case report of our patient, the 68-old-year man, medicine doctor, pathologist, pensioner, former smoker, 20 package years, hospital admission, acute exacerbation of COPD, VIX, X-ray confirmed pneumonia, bacteriologic Pseudomonas aeruginosa, combination therapy, intravenous peroral continual oxygen therapy, control X-ray in 10 days, you will see the regression of the infiltration, bacteriologically sputum conversion, lung function test. So this was how it was at the admission and on the release, and exactly the FEV1 is plus 18%. So these were the session number, duration, and how it was, what type of program, the power, and exactly expectation during the session and after the session. The most important is also that not after the first session, you need to have to wait that it will be a huge amount of sputum expectorated, but after this, it's started by the third, fourth, exactly by the COPD patient. It is, you need after the, not after the first, but after minimum after the third, fourth session, then the quantity of sputum is coming higher and higher. It's not like by cystic fibrosis patient and younger patient when it is a relatively stable amount of sputum. By COPD patient and older patient, it also takes how it is the examination is proposed. So lung function test results demonstrated an improvement in distal flow rates. Maximal improvement in FFV1 was 330 milliliters. Contributing to a frank improvement in this quality of life are feelings freedom in the airways, less prolonged expiration, noisy breathing, decreased lung hyperinflation, improved physical performance. So from the first autogenic drainage session combined with the SIMEOX, the secretion became increasingly abundant and expectoration easier. The patient adapted very quickly to the device and even contributed to the improvement of its usage protocol throughout the quality of his feeling. And when we are going to the groups of the patient who may benefit from SIMEOX treatment, so these are exactly, yes, cystic fibrosis, and I have to speak now about this, that yes, SIMEOX, exactly, we started in all of our countries, we started with cystic fibrosis patients. At the moment, the patients are falling down with physiotherapy because, yes, we have the new treatment for the patient, but still, it is necessary that the patient need to think that, yes, physiotherapy will be benefit for him because they cannot stop all the physiotherapy. Bronchiectasis, COPD, a progressive lung disease often caused by smoking, where mucus build-up can contribute to breathing difficulties, and primary ciliary dyskinesia, it was, and non-cystic fibrosis bronchiectasis with chronic mucus hypersecretion. Potentially new group who may benefit also asthma patient with mucus hypersecretion, like it was mentioned by the first patient, first case report here. Acute respiratory infection, post-surgical patients, exactly individuals recovering from lung surgeries or major thoracic surgeries may develop mucus retention as a complication. SIMEOX could help in the rehabilitation process by facilitating mucus clearance. And as we know, also patients with neuromuscular disorders, like amyotrophic lateral sclerosis, muscular dystrophy, and multiple sclerosis. And yes, we are happy for this, that we have the possibility that our patients have the possibility to have the machine at home, but still, and paid, who is paid by the health insurance companies. But on the other hand, yes, COPD patient, we would like to add back again, as it was in the start, but it's a little bit longer run for longer distance, because it is with the health insurance companies, they do not fully agree by the COPD, smoking, and so this is the never-ending discussion. But who will be benefit also? There are the obese individuals with sleep apnea and obesity, hypoventilation syndrome, and also now the patient with chronic sinusitis and pulmonary hypertension. And with the flows of the picture of our mountains, how it was after the Easter, exactly, these are the picture from Monday morning. So many thanks to your attention.
Thank you very much, Professor Solovic. I could visit Vishnehagi once, and I am really very impressed with that, what you do. Thank you for this comment about looking for potential new groups who can benefit from SIMEOX therapy. But there is one aspect which you touched, and I want to ask all of you for. I work in a center where we do not transplant the lungs, and I am completely unexperienced with lung transplant patients. But do you know if there is any experience with SIMEOX therapy with this group of patients in Switzerland, Poland, or in Czech Republic? Do you know anything?
In our department, we don't have any experience with transplant. There are transplant in Prague and Brno.
Okay,
so
okay.
Not in our university hospital.
Oh, well, maybe I will add something. Maybe I not work in a center who is experienced with lung transplantation. However, I send lots of patients to the lung transplant centers, and well, I'm in a contact with them, and I know that SIMEOX therapy is there a huge and interesting tool that helps the patient, and even well, we discussed that the patient may be taught how to use it before the lung transplantation, and I hope I will just show you why in my presentation.
Okay, fine, thank you. And Switzerland?
Yes, thank you. Yes, we transplanted our center. I am not aware of our experiences post-transplantation, but I don't know why there will be contraindication from transplantation to use the device. Maybe someone can explain me. In pre-transplantation, yes, it's possible to use in some patients with bronchiectasis or cystic fibrosis, but I am not aware about use of that in post-transplantation. I can ask to my colleague that take in charge of those patients, but I am not aware.
So it's interesting. It should be discussed, and we can see that it's open area.
So may I comment to this? So in pediatrics, we have very few transplant patients, but I think that the main contraindication or the main worry about that would be the dehiscence of the anastomosis after the surgery, but when everything is healed, so I think that there is no problem. Indeed, we have a few patients with cystic fibrosis after lung transplant, and we did SIMEOX in them. Yeah.
Thank you, Dr. Kołucki. Great. I think that we were of opinion that bronchiectasis and SIMEOX, it's mainly area of patients with problems with obstruction, but I understood that also restrictive diseases are a group of diseases where bronchiectasis can appear. And now, please let me invite Dr. Joanna Milkowska-Dymanowska from Łódź, from Center of Poland, who will share with us her experience. Joasia, please.
Thank you for your kind invitation, and I welcome one more time everyone. Well, I would like to talk today about my experience and emerging perspective that I observe in my life and my clinical practice. Well, of course, I'm mainly interested in idiopathic bronchiectasis because, well, it's a really huge problem. We know that the number of cases increase, and the risk of mortality in this group is really high, and well, we also hospitalize those people quite often. Well, usually we think about the patients with very characteristic CT imaging and with clinical symptoms like cough, sputum production, and recurrent infections. However, if we look at the EMBARC registry, you can see that bronchiectasis is not only the problem that is connected with COPD and asthma and obstructive diseases. The biggest number of the patients are the patients with idiopathic bronchiectasis, and the second group is the patients with post-infective bronchiectasis. Well, if we think more what is the etiology of bronchiectasis, you can see that idiopathic bronchiectasis, but also other genetic disorders, and very interesting, also autoimmune disease are very important in this case. Even if we check the British Thoracic Society guidelines, you see that if you diagnose bronchiectasis, you should check at the patient and see maybe there is underlying autoimmunological disease. Well, and then rheumatoid arthritis is the first disease that I always think when I've got bronchiectasis. Why? Because, well, according to the pathogenesis of this disease, there is a strong theory that rheumatoid arthritis starts in the respiratory system. And, well, if we do high resonance CT, we can see that even 1/3 of the patients got bronchiectasis, not always symptomatic. However, it may complicate the use of immunosuppressive medications, and always are the independent risk factor of lower respiratory tract infections. Well, also, if we do high resonance CT, we can also find the early stage or just interstitial abnormalities, and later we can also see the typical changes that are for interstitial lung diseases, and well, we know that this group of patients got the higher risk of death. What's interstitial lung diseases? It is diffuse, non-infectious, non-malignant disorder that affects mainly parenchyma, however, also vessels and, very important, bronchioli. ILD, it's, more than 200 entities, very heterogeneous group of patients. And, well, we know that the symptoms are also very non-specific, like in bronchiectasis, dyspnea, fatigue, cough. And, well, the problem might be inflammatory, like the picture that I'm showing you, the pattern of non-specific interstitial pneumonia and, well, gland grass opacities that are typical for inflammatory disease. However, the progress of disease may be into fibrotic, and then the bronchiectasis, traction bronchiectasis, and central traction bronchiectasis are very important, and I believe that is also the symptom of the problems that they progress. The cough and the dyspnea and respiratory failure is the problem in this case. Well, it might look like the previous one, or I just showing you the other my patient with restrictive disease with sclerodermia and ILD, and you can see that the changes are here also with fibrosis. However, also we see huge bronchiectasis that are the ending stage of this problem. Well, so I showed you the patients with progression of fibrosis. Now I'm trying to show you the other case that might be in a lung parenchyma. We may have alveolar damage, and those patients with alveolar hemorrhage requires usually quite intensive care and immunosuppressants, chemotherapy. Those patients are treated for 6 months, and sometimes after the main active phase, after induction of remission, we've got the patient with stable state and with controlled autoimmunological disease. However, the damage after the treatment might be like in this case with a huge bronchiectasis. So just to sum up, well, the patients may progress into a problem with bronchiectasis, maybe some kind of complication after the treatment, and we may have the other diseases that just will be with flare-ups, like in hypereosinophilic syndrome or EGPA, so where the cough, dyspnea, and hypersecretion of the mucus might be recurrent and might be the first symptom of the disease, and then eosinophilic inflammation in airways might be the first symptom, but remember it's the disease with multi-system organ involvement, so sometimes we may miss those symptoms. And well, the last example of the patient is the patient that I treated in my SIMEOX therapy in 2021, and well, I'm showing you the lady when she was in her in 2019, when she mainly got problems connected with bronchiectasis, and well, bronchiectasis and some kind of fibrosis that progressed, and the lady was with cachexia, respiratory failure, and well, the problem with her fibrosis, with her cachexia, and with her hypoxemia was so severe that the symptoms were at rest. So the dyspnea was at rest, MRC was 4 almost all the time, and she started having very acute exacerbations with infections, and then adding the rehabilitation with SIMEOX really helped. May need to reduce the chest discomfort, and well, I'm showing this as a case because I believe that it was so significant. The chest discomfort almost disappeared. So at the beginning of the treatment, the lady got 10 and said that in the scale VES was maximum, and after the treatment was completely 0, so disappeared. However, the tiredness and exhalation problems stayed because she really suffered from ILD disorder. Well, that's my experience. So I believe that the patient needs some kind of precision medicine, individualized therapy. And I can show you now one of the latest review that underlined that it was written by ILD experts that treating ILD, it's not only ILD, but also we should just think more about the comorbidities and well treat them at the same time, and well it should be some kind of tailored approach to the problem. So we not only focus that it's only COPD. Probably if there's COPD with bronchiectasis, we should treat the patient according to the rules to those diseases. And the same I think is in ILD. If you've got ILD and you see that the problem is with cough and mucus plugging in distal airways, maybe we should try some kind of innovation, just because it's the tailored treatable trait for those patients. And I think that we need more data, and maybe we're sitting here right now to just produce a new research and study to prove our work. And I hope that this discussion will help us to find out new research ideas. Thank you very much.
Joasia, thank you very much. It was excellent. I think that 2 words started with I are my favorite from your presentation. The first one is individualization, and the second is innovation. I think it is something what you touched very precisely. My dear, making connections and finding solutions, it is something what I like very much working every day. And meeting with you let me feel I can do it today. So thank you for your presentations. But very important people are these who now listen to us and watch us. So maybe let's check if we have any questions. Okay, I have first question, and I think it will be for you. I want to ask you about monitoring of patients with bronchiectasis. Can you tell us what are the tools to monitor these patients whom we treat with bronchiectasis and, for example, with SIMEOX therapy?
Well, I can tell you that, well, in my patients with idiopathic bronchiectasis, I use CAT scale. It's, we've got evidence that it's validated in this group of patients. And, well, what I can say, it's not now published, but we finished a study that just shows that we can assess the significance of the monitoring using this tool, and well, it's quite easy to do in practical way, because well, all others questionnaires are quite long. This one is, I think, enough. It helps to use it, and I'm trying to use it also with my ILD patients. It's maybe not so clear, but now when I validated it in my group of idiopathic bronchiectasis patients, I also try to do it with ILD in my clinical practice. So CAT test. Quite old, but very well
It's a very useful answer, because CAT is used by all of us, and everyone who cares for COPD use CAT, but we do not realize it's also useful tool for bronchiectasis.
Airway assessment test.
Yes,
yeah. So not only COPD.
Okay, and next question. How much time do we need to stop the SIMEOX treatment after hemoptysis or embolization? Or if the hemoptysis is very mild, painted sputum only, can we keep on the same treatment? Dr. Kopecki, can you try?
Yeah. So I think that it depends if the patient is treated by some anticoagulants or not. Yeah, because if there is any hemoptysis or painted sputum, so I can stop. It's my decision. I can stop using the SIMEOX or any therapy which can worsen the patient. So it depends. So maybe if there is only mild risk to continue using of the hemoptysis, so we can continue in several days, maybe 2-3 days, when the patient is in stable status. But it's individual, and it depends on the diseases, on the complications, if it is after the therapy or something else. Yeah, so
okay,
it depends.
Do we agree? I do.
I agree also, and maybe in case it is the hemoptysis is very mild, painted sputum only, that it depends also what was the, if it was 50%, then we can let it go down with the percentage, so to go to the milder treatment session, so that to go down to 25%, and so not to exactly not necessary in painted sputum only. You can do the milder session of the SIMEOX therapy. So this is one of my recommendation. But yes, it depends what was the hemoptysis, what was the cause of the hemoptysis.
Fine, thank you very much. And the next question, I think not so easy. Mechanism of SIMEOX action in COVID pneumonia. Any volunteer? If not, I will start, because when we had COVID-19 pandemic, I worked a lot with COVID patients and care for them for more than 1 year. And I am not sure if I am right, so please listen to what I say, but I think that generally, if we have clear viral COVID-19 pneumonia, it is interstitial pneumonia, and there is no problem with secretion inside bronchial tree, so I cannot find any indication for SIMEOX here. But of course, if I have a patient with coexisting problems like bronchiectasis, it could be a place where standardly SIMEOX therapy could be used.
I completely agree. This is mostly the SIMEOX action is like any other airway disease. This action is has been described, but yes, the many patients surviving COVID pneumonia have bronchiectasis consequence, and this patient can be the patient who can be beneficial from this treatment.
Thank you for this comment. Okay, and now, Claudio, having you here with us, I must ask you one question. When you started this meeting today, you mentioned about neuromuscular disease patients, and I completely agree that we know that it is a standard for us to measure peak cough flow among this group of patients, to check if it is a patient who needs cough assist or not. However, in my center where I work, we do not do it routinely among COPD patients. Independently, we know that COPD is a disease which can touch muscles and decrease effectiveness of working of pulmonary pump. So do you think we should also measure more frequent peak cough flow among COPD patients?
Thank you very much for this very challenging question. I think that the COPD is complex to try to order the answer. I think that clearly, as you said, COPD is not only a parenchymal and bronchial disease, it's also a muscular disease. And those patients are not only muscular atrophy or muscular dysfunction, but also hyperinflection. Put the respiratory muscles in a relationship with longitude and tension that is not effective. So we have some experience with insufflation, exsufflation technique in patients with COPD at the end stage of the disease in which there is not effective cause. The problem is that maybe this technique of SIMEOX could be useful because those patients have in general mucus impaction and that are clearly not taken into account in the management of them. And I think that now we have a paradigm that changed, that is, we are reading, we are seeing, we are regarding in the deep lung when we analyze in COPD patient, not only in terms of bronchodilation, but also in bronchial emptying. So I think that there are two different problems. The first problem is muscular problem. And when you evaluate this muscular dysfunction in those patients, we need to take into account that peak flow is not the best technique, because peak flow reflects both the muscular dysfunction but also the collapses of the airway. And clearly we use peak flow in asthmatic patients to evaluate the bronchodilator activity and the risk of complication of the asthma, the acute asthma attack. So I think that we need to evaluate deeply the respiratory muscles in those patients, but I don't think that peak flow is the best way to do that. After then, it's useful to apply insufflation, exsufflation techniques in those patients, maybe in some subset of patients with diaphragmatic dysfunction, with muscular atrophy and muscular disadvantage of diaphragm. It could be useful to increase to remove secretion, but I think that this is not the first technique to be used in those patients. I think that we are other techniques for removal secretion in these patients than the insufflation, exsufflation, and maybe SIMEOX is a good technique as to try. Yes.
Claudio, a question was challenging, and the answer was perfect. Thank you. My dear, now is a time for a promise. A promise is that we decided all together that after this meeting we try to summarize our discussion and answers for your questions in short document which will be prepared after this meeting and will be sent to all of you to have this knowledge in Pil after this meeting in Hradec Kralové. Now it's time to summarize. It's not so easy because a lot of different new ideas appear. However, I think that I am sure we started to stop our vicious circle, which I started with. I think we can agree that it's not possible to treat patients with lung diseases without physiotherapy. I think we can agree that airway clearer techniques are crucial among patients with bronchiectasis. I think that we agree that SIMEOX therapy is a unique technique which can be beneficial among various groups of patients, and we should always think about individualized therapy where SIMEOX should be taken into consideration. We have data about improvement of mucus clearance, improvement of lung function, increased physical activity, reduction of respiratory symptoms, and improvement of health-related quality of life thanks to using of SIMEOX therapy. We should agree that SIMEOX therapy is a successful solution and should be always thought about whenever we have a patient with bronchiectasis, independently on that, what caused this bronchiectasis. I am looking at you.
I agree.
I can see smiles. So I think it's time that we are on perfect time to finish this meeting. Thank you, all of you. It was a privilege for me to meet so excellent speakers and to have these 2 hours together with you, which passed very shortly for me. And thank you, first of all people who came here and all internet audience visitors who took their time to be with us for these 2 hours. And thank you, of course, PhysioAssist and Indian company who helped us to organize this meeting to open our thinking about that, how valuable technique can be SIMEOX, and how important is to always remember about airway clearance therapy methods. Thank you very much and see you next time.